Good morning. My name is Tom Rizzo. We're here at the annual assembly of the American Academy of Physical Medicine and Rehabilitation in Atlanta, Georgia. And I've got the distinct honor of being with Dr. John Whyte, who's the director of research at Moss Rehabilitation Research Institute in Philadelphia. John, thanks for joining us.
My pleasure.
John, tell us about research in physical medicine and rehabilitation. Perhaps, why don't you talk about your research first?
Well, I've been interested in traumatic brain injury for a long time. That's really been the subject of my research since I completed my residency. I'm trained also as a cognitive psychologist, so a lot of my research has focused on cognitive impairments that result from traumatic brain injury. And I've really had kind of two strains of research that have gone in parallel through most of my career. One studying higher level patients with attention and executive deficits after traumatic brain injury, and then another line of research that involves patients in prolonged states of unconsciousness, so the disorders of consciousness and recovery from them.
Okay. So we've heard a lot about traumatic brain injury, and so your research is focusing on helping these individuals regain their capabilities?
Yes, I mean the current interest in traumatic brain injury, of course, has very strongly influenced, been influenced by the mild traumatic brain injuries that we see, especially in the recent military conflicts. My work has always been with moderate and severe injuries, so patients who have pretty obvious and disabling cognitive impairments. And we've done work on trying to understand the nature of those impairments. We've developed some assessment tools for measuring attention problems in TBI, and then we've done some work on pharmacologic treatments in particular. And similar in the patients with disorders of consciousness, finding better ways to measure their accurate level of consciousness, and ultimately organizing a multi-center network to do clinical trials in that population.
So what about you mentioned the pharmacologic, the drugs that are used. Are there some new research and data that's come out on that?
Well, yes. I mean, it's somewhat frustrating in the sense that my career, we've been talking about the same set of psychoactive drugs that might be helpful for traumatic brain injury for about 20 years. And we have, up until recently, about the same amount of evidence about the efficacy of those drugs for 20 years. So part of that, I think, has been that we are very reluctant to not treat anyone. We don't come from the placebo school, and so we, including myself, have tried to find research strategies for gathering evidence of efficacy while treating everyone. And over a number of years, despite trying single subject experimental designs and other approaches, I ultimately came to feel that in many instances it's not going to happen. And so we did ultimately organize a multi-center network in the United States and in Europe of investigators and facilities who treat patients with disorders of consciousness and who are interested in research with them. And over really a 14-year period, we first organized the network, then did some natural history studies that would help us understand what recovery looks like with current treatments so that we'd be able to plan a really good study. And then we, last year, completed a 6-year randomized placebo-controlled trial of amantadine. And that was published in the New England Journal of Medicine on March 1st of this year. And I believe was the first study to show that a pharmacologic agent could accelerate recovery from a neurologic event. So we showed that the amantadine group made faster gains during the period of treatment.
So that's exciting.
That is exciting.
But as you point out, it's taken a decade and a half to get to that point. Would you say that's the challenge with research in this area?
Well, I think there are a lot of challenges, and ironically, I would argue that pharmacologic research is the least challenging, and yet that was hard enough. But I think that in most of our treatment facilities, we have relatively small numbers of patients who stay for a long time. So it's hard to enroll large samples with any particular problem. So that almost pushes us into multi-center work for most topics. There's not very good funding, I think, for much of the research we do, because so much of the research in other areas of medicine is funded by corporate support, and there aren't very many drugs that are sort of big market rehab specific. So the pharmaceutical companies don't tend to support, and there's not enough public support either. So indeed, between the administrative organizing and the getting the money to do the work, it's really challenging.
So in your role as a director, beyond your own research, what other responsibilities do you have?
Yes, I'm the director of the Research Institute at Moss, which is a hospital-based research institute. And when I came there, and I was the founding director with my associate director, Myrna Schwartz, when we started the Research Institute, we had 1.5 FTEs of scientists and a couple of support staff. And so our job really was to develop a strategic plan to build a research program. And that involved, among other things, getting the support of the board of our institution to raise an endowment to support the research, which they generously did. Over a number of years, we were able to hire a number of scientists, faculty equivalent scientists, so that we now have 9 individuals who are principal investigators, most working in areas related to cognition, but recently we had approved a business plan to build a movement science component. So we've gotten some additional resources, and we're on a bit of a hiring spree. We just hired another person. We will be hiring at least one more person in the next couple of years. So that's the other focus for me, has been to try to create a vision for, and then populate that vision for, a rehabilitation research institute, and to find a way to fund it, which we've managed to do for over 20 years now.
That's great.
Yeah.
And as part of that, you also have trainees?
We do.
Younger scientists?
Yes.
Or physicians going into clinical research?
Yes, we don't. We're not. I mean, we have university affiliations, but we're not. Our research institute is not university-based in any official way, and so most of our training involves postdoctoral trainees. Occasionally, we get graduate students from collaborating scientists, but more often we get postdoctoral fellows. We've had a NIH-funded T32 program, and we also have some internal funding. And so typically we have 3 or 4 postdocs in our institute in any given year, and actually we have a training grant under review now, and if that gets funded, we will be able to expand our training program.
Very good. That's great. So in speaking to young physicians, young physiatrists coming along, what would you tell them about getting involved in research or looking at research as a career?
Well, certainly for me personally, it's been incredibly fascinating and rewarding. It's a very challenging career because you have to be looking for money all the time. And it's very delayed gratification. You might work on a project for 5 or 6 years before you really have interesting findings to publish. But on the other hand, when you're in a field that is in such need of evidence, the opportunity to provide some of that evidence is very gratifying. And I must say, for me personally, working hard is a lot more fulfilling if I decide what I want to work on. And one terrific thing about a research career is that I can pretty much do whatever I want as long as I can find the resources to support it. And so I've had the same job for 20 years, but I'm doing something different every year. And so I think if you're a person who's creative and you like personal autonomy and you're willing to work hard, it's a really terrific line of work.
So can you tell us what's going to be different next year? What's the next excitement coming along?
Yeah, well, we've had this is now our fourth cycle of having a traumatic brain injury model system grant from NIDER. My colleague Tessa Hart is the principal investigator of that, but I'm very involved, and so I'll be taking on a project starting now to develop a pain scale for patients who can't communicate their level of pain. And I'm also working with colleagues to try to figure out the next step of our amantadine research. Ironically, we've made it harder for ourselves because now no one's going to want to be in a placebo-controlled trial, and we have to find innovative research designs for answering the remaining questions about the drug, of which there still are many.
Great. Anything else you'd want to tell our audience about research in PM&R, or a message to the general community?
I think in addition to the personal reasons for being interested in research, I think we can anticipate that under healthcare reform and an increasing emphasis on evidence-based practice, that we're going to have to do research. We're going to have to find out what really works and what doesn't, and trim down our activities to the things that really make a difference.
All right. Well, John, thank you very much for spending this time with us. I'm here with Dr. John Whyte from Moss Rehabilitation Research Institute in Philadelphia. Thank you for tuning in.
Thanks.